This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery, and today we are diving into a topic that often keeps us up at night when managing large skull-base lesions.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the Journal of Neuro-Oncology, published in 2026, titled Pseudoprogression in Koos Grade 4 Vestibular Schwannomas Following Stereotactic Radiosurgery, Temporal Dynamics and Radiological Predictors. It comes out of the Gamma Knife Center at Elizabeth II Steden Hospital and several Dutch academic centers.
This is a timely paper, Ilara. For years, the gold standard for Koos Grade 4 vestibular schwannomas, those large tumors with brainstem displacement, has been microsurgery. But we've seen a shift recently. Stereotactic radiosurgery, or SRS, is increasingly being used for these larger tumors, especially in patients who are minimally symptomatic or have high surgical risks.
Exactly. But the elephant in the room with SRS for Koos 4 tumors is pseudoprogression. If a small tumor swells a bit, the patient might have some transient dizziness. If a Koos 4 tumor swells, you're looking at potentially life-threatening mass effect on the brainstem or acute obstructive hydrocephalus.
Right, and that's why this study is so important. They looked at 258 patients, all with unilateral, sporadic Koos 4 tumors larger than 4 cubic centimeters at the time of treatment. That's a significant cohort for this specific grade. What did they find regarding the incidence of pseudoprogression?
They found that pseudoprogression occurred in 29% of these tumors. For our listeners, that's 75 out of the 258 patients. This is actually quite interesting because it suggests that the rates of transient enlargement in these large tumors are actually comparable to what we see in smaller Koos grade 1 to 3 tumors, which usually range between 18 and 72% in the literature.
That's a reassuring starting point. It means the biology of the radiation response doesn't necessarily become more volatile just because the tumor is larger. But in a Koos 4, the timing of that swelling is everything. What were the temporal dynamics?
The median time to peak volume was 8 months, with an interquartile range of 6 to 14 months. So the majority of the swelling happens within the first year. At that peak, the median relative increase in volume was 23%.
A 23% increase on a 7 cubic centimeter tumor is not insignificant. That could mean an extra 1.5 to 2 cc's of volume in a cerebellopontine angle that's already crowded. Did the authors identify any predictors that could help us tell which patients are most at risk for this?
They did, and this is the most clinically relevant part of the paper. They looked at various MRI-derived predictors. The standout finding was the presence of microcystic components. They defined this as having one or more small to moderate-sized intratumoral cysts.
And what did the microcysts tell us?
It was actually an inverse relationship. Multivariable logistic regression showed that the presence of microcystic components was significantly inversely associated with pseudoprogression. We're talking about an adjusted odds ratio of 0.15.
That's a very strong association. So if you see those small internal cysts on the baseline T2 or post-contrast T1, those tumors are actually less likely to undergo significant transient swelling?
Precisely. The authors suggest that these microcystic tumors might actually be more suitable candidates for SRS because their volume response is more stable. On the flip side, they looked at macrocystic tumors. Those where cysts make up more than 50% of the total volume.
Macrocystic schwannomas have always been the bad actors in radiosurgery. What did the study show there?
It was much more variable. They actually performed separate annotations for the solid and cystic components in these tumors. In about half of the macrocystic cases, 19 out of 39, the solid and cystic components had completely different response dynamics. You might have the solid part shrinking while the cyst expands, or vice versa. This independent dance of the cyst makes macrocystic Koos 4s very unpredictable.
That aligns with my clinical experience. When a cyst starts to expand rapidly post-SRS, it's often an osmotic or inflammatory process that doesn't follow the standard rules of solid tumor shrinkage. Let's talk about the failure rate. In this study, how many patients ended up needing a second intervention?
Ultimately, 30 patients, which is about 12%, required an additional intervention. The median time to that second treatment was 36 months.
12% is a respectable number when you consider these were all large brainstem compressing tumors to begin with. It means 88% avoided surgery during the follow-up period. For a resident or a fellow like yourself, Ilara, how does this change how you counsel a patient in the clinic?
Well, if I'm looking at a patient with a Koos 4VS who is a candidate for Gamma Knife, I'm looking very closely at the T2 weighted images. If I see a solid tumor with microcystic features, I can be more confident telling them that their risk of dangerous swelling is statistically lower. However, if it's a macrocystic tumor, I'd be much more cautious. The study explicitly states that macrocystic tumors warrant careful monitoring due to those variable dynamics.
And the 8-month peak is a great rule of thumb for our listeners. If you can get a Koos 4 patient through the first 12 to 14 months post-SRS without a clinical decline, the odds of them requiring salvage surgery for pseudoprogression drop significantly.
I also found it interesting that the median tumor volume in this study was 6.8 centimeters cubed. Some of these were quite large. The authors pointed out that while surgery is often preferred to avoid radiation-induced mass effect, SRS is a viable alternative for the selected Koos 4 patient.
It really comes down to mass effect versus tumor growth. In surgery, we remove the mass effect immediately, but take on surgical risks. In SRS, we risk a temporary increase in mass effect to gain long-term control. This paper gives us the radiological tools, specifically looking for those microcystic versus macrocystic features to weigh that risk more accurately.
Definitely. And just to recap for the residents listening, pseudoprogression in Koos 4 occurs in about 29% of cases, peaks around 8 months, and if you see microcystic components, you can breathe a little easier, knowing the RR for pseudoprogression is only 0.15.
Excellent summary, Laura. This study from the 2026 Journal of Neuro-Oncology is a must-read for anyone involved in skull-based multidisciplinary teams. It provides a data-driven look at the temporal dynamics of these challenging tumors.
Thank you, Dr. Aris. It's always great to see studies that help us move toward more individualized counseling.
Agreed. That's all for today's episode of the Neurosurgery Hub podcast. Join us next time as we continue to explore the frontiers of neurosurgical research. I'm Dr. Aris.
And I'm Dr. Alara. See you next time.